Thank you, Dr. Lucy, and thank you for giving me an opportunity to present in your course. At the outset, I have no financial disclosures about whatever I'm going to speak. So, LASIK has been, myopic and hyperopic LASIKs have been done over years. So now we're going to get a lot of patients who will develop cataract. So now, if patients have been of freedom from glasses for the entire age, when they get cataract, they're going to expect that, I want spectacle-free life after my cataract surgery also. So the next question would be the option here is multifocal lenses, but can we consider implantation of multifocal IOLs in post-LASIK patients? Literature says yes, even after hyperopic or myopic LASIK, you can go ahead and do a multifocal intraocular lens implantation and you have a good accuracy and predictability of the outcomes. But how do we plan this? Like, what is the right approach to have a multifocal IOL post LASIK surgery? And when do we do it? When do we do not do it? So this is a slide which talks about if your cornea is regular, which is like a virgin cornea, how the optical quality would be in assessing your IOL power calculation. But if it LASIK is done, and then the optical, if it's a well-centered ablation, your optical quality might still be okay. But if it's a decentered or a highly aberrated cornea, the optical quality of the cornea would be not very great, and all this would impact our IOL power calculation. So it is very important for us to see that what is the optical quality of the cornea, how regular your cornea is, and then if you would implant a multifocal lens or not. So the stepwise approach would be to do a slit lamp examination and fundus examination first. Whatever holds true for your normal multifocal IOL patients like virgin eyes tends true here also. If any corneal opacities or neovascularization of iris or zonular dialysis or phacodonesis is there, then you would like to avoid of multifocal lenses. Or even if there is any retinal conditions present, then you would avoid doing a multifocal lens for this patient. So this holds true, and these are most of them are high myopic patients or hyperopic patients. So it is very important that to rule out these conditions before doing it, and they might be at higher risk of myopic CNVM. So that also needs to be elucidated. The next would be dry eye assessment. As these are post LASIK patients, they might be having higher risk of dry eye, or their surface might not be extremely healthy. So we need to do a detailed dry eye evaluation for them. And as we are doing a premium IOL, a meibography or an optical quality analyzer system or doing an epithelium map would be very much helpful, and it would help us plan whether it's possible or not. If the surface is unhealthy, then you treat the surface with one of your drops and then take the patient up for surgery. Then would be a corneal topography. We see that whether the ablation is centered or not. You look for the aberrations and you look for the EKR map if you have a pentacam. If it's a well-centered ablation, then you can go ahead and probably do a multifocal lens. But if it's a decentered ablation, then it's not a wise idea to do a multifocal lens. Also, EKR, it provides the estimation of the corneal power in post-refractive surgery eyes. And it gives value of mean corneal power in different zones centered around the corneal apex. It takes it, and we take into consideration the 4.5 zone for our calculation. But let's see what a good EKR map would be: a single peak with a narrow base. The astigmatism would be regular across all the zones, and also the EKR mean. But the bad EKR map would be multiple peaks or a broad base or both. And the astigmatism, if you can see here, would jump from anything like, more than one. So it can jump from 1 to 5 diopters also. So it is not a good idea to do a multifocal lens for this kind of patients. And the next would be aberrometry. We look at the aberrations, the higher order aberrations, basically whether they are normal or not. If they are less than 0.5, you can favor for a multifocal lens. But if they are higher than that, then it's unfavorable for a multifocal IOL, even if the centration or the ablation is centered. And even you can check from the eye trace whether the corneal higher order aberrations are on the lower side or on the higher side. If there is any corneal irregularity present, conventionally you would put an IOL and then do a LASIK correction. But for multifocal IOLs, this doesn't hold true, because you can land up in a refractive surprise, which will be a mess for our clinicians. So we do a TCAT followed by IOL implantation, regularize the cornea for a better corneal shape and curvature, aberrations and all, and then we have better predictable and better outcomes. And these two papers I just talks about how you regularize the cornea and then go ahead and do a refractive a cataract surgery. So, and if you are doing a refractive correction or a regularization of the cornea, you would at least check for the stability before doing a cataract. And the topography should be stable for at least 4 weeks over 2 time points, or wait for 3 months before doing a cataract surgery if you have done a corneal customization. And also this is a flow chart. Then when you would, if it's a cornea is centered, then you would go ahead and do a cataract surgery. If not, then topo guided treatment followed by a cataract surgery. The next would be also important to see an angle alpha and angle kappa, because if angle alpha is less than 0.5, then it's favorable. But if it's more than it will lead to a better centration of multifocal IOL. But the angle kappa alpha is larger, then you can land up in a poor quality of vision post IOL surgery in spite of having a emetropic eye. So this is just a summary of when to do, when not to do. And the most important part here would be to also a patient should be motivated and have realistic expectations. Also, you have to explain the patient very nicely about the neuroadaptation time, because the brain, you need to allow the brain to suppress some of the these pathways to have a good outcome and avoid those glare and halo. So you have to explain the patient about the neuroadaptation time also, and especially in post-LASIK eyes. As I said, patient counseling is extremely important. You have to give them realistic benefits. It's always better to under promise and over deliver, so your patients are always happy. If you over promise and under deliver, both your and patient's life are going to be happy. And after explaining the neuroadaptation, the very important part would be the informed consent. If it's a post-LASIK multifocal IOL, you have to always tell the patient that it is, there can always be a chance of refractive surprise. You are going to try your best, but if there is a refractive surprise, they might have to wear a contact lens or a glasses after a multifocal eye surgery, and which is known in LASIK surgery. So you have to take a extremely special informed consent in addition to your normal cataract consent. So choosing the right formula would be the next step would be choosing the right formula. There are various formulas which are used for post-LASIK eyes. Holiday 2 and Barrett-Truquet formula. Barrett-Truquet formula always stands the test of its time. And you have an ASCRS calculator also, where you feed in all the parameters, and at the end of it, it will give you which IOL power to take into consideration. 99% of the times you'll go ahead and take the average IOL power which the calculator gives us, and you would go ahead and implant a lens. Surgical pearls would be, you should have a stability of the bag, and the rhexis should be well centered, because a decentered rhexis can cause iatrogenic tilting or of IOL, and it can also lead to dysphotopsia. So intraoperative pearls, it should have a well centered rhexis and a stability of bag. If the bag is not stable, or if you feel it's a little bit of zonular weakness present, always put a CTR before going ahead with the lens. This is also just how you will choose the IOL based on the previous LASIK surgery history, whether to choose a negative or a positive SA IOL or a aspheric IOL. There are various available in the market, bifocal, trifocal, quadrifocal, and extended depth of focus from various companies. So based on your experience and your preference, you can choose whichever IOL is the best works for you. But in our experience, an extended depth of focus IOLs works the best, like Symphony or Eyehance lens also works the best for our patients. And literature also says that the extended depth of focus works the best for if the patients have a previous laser surgery history. So just take home points would be patients, yes, you can do a multifocal lens for post-refractive surgery eyes, but it is very important that you counsel the patients extremely well, give them realistic expectations, avoid doing it in a decentered cornea or a highly aberrated cornea, or if you have any of the conditions like scarring or that something, please avoid doing it. Otherwise, you can go ahead and do a multifocal IOL. For this, I would like to thank my entire team from Narayan Nethralaya for giving me this opportunity and helping me put up this work together. And thank you, Lucy ma'am, once again.